Hello everyone, welcome to the class of Pediatric Nursing on our topic Pathophysiology, Pharmacology, and Nursing Care on Neonatal Prematurity, Low Birth Weight, Respiratory Distress Syndrome, Asfiksia, and Hyperbilirubinemia. Today's objectives are to learn about prematurity, low birth weight baby, respiratory distress syndrome, asphyxia, as well as hyperbilirubinemia. So before we move forward, what is the definition of newborn with high risk? So WHO mentioned that the baby within 28 days of life has a very high risk for that. And that's why baby can have adaptations which starting from the intrauterine stage to intrapartum stage and to extrauterine stage. So baby needs to make a lot of adaptations to the process of life, from the pregnancy to the delivery, as well as living outside as human. And there are a few risk factors that can compromise the newborn. The first one, when it happened intrauterine, is the genetic disorder, congenital abnormalities, maternal diseases, trauma, and drug use. So if the mother has a trauma or mother has like a maternal disease such as hypertension or diabetes, it will also contribute to the baby, so the baby will have a high risk when it's being born. An intrapartum setting, if baby during the birth having asphyxia, having birth injuries, having complications during labor, and it is a birth of multiple gestation baby, and then having a poor presentation to birth and also having maternal infections on the way during the delivery, this also will contribute to baby to have high risk. And in extrauterine setting, once baby has hypothermia and poor oxygenation, and baby was born premature with congenital anomalies and also metabolic disorder, this will make the baby having a very high risk. So we need to understand that newborn with high risk have a few maternity standards that they need to get. So the first one is lung maturity, because the lung maturity needs to happen before the 30 weeks of pregnancy. Once the baby shift from the live intrauterine to extrauterine, the baby needs to have their own respiratory system. If the baby did not have a mature lung, it means that the baby will have the risk to have respiratory distress syndrome. And another one is circulatory maturity. So once the baby breathes the first breath after birth, the baby also needs to kick in the circulatory system on the body, because all the holes that was there, all the shunts need to be shut, so that the baby can start the process of cardiovascular or circulatory system on her own. And some changes will happen if the baby have a fragile circulatory system. So the baby is preterm, so it doesn't work yet, so the baby may then have problem also. So the third one is about neurology maturity, where the central and peripheral nervous system will be affected, as well as the parasympathetic and sympathetic nervous system. So we understand that once the baby born premature with high risk, it means they will have deficit in neurological, which will happen for a short time or even for a long time. For the baby with high risk, there are a few risk factors that are also contributed by the mother during her pregnancy. So it really needs to make sure that during pregnancy the mother is healthy, so that the baby also will be healthy. So a newborn with high risk can be categorized into two. Newborn high risk because of a gestational age, which divided into three. Preterm, so when the baby born before 37 weeks. Term, born 38 to 42 weeks. And postterm, born after 42 weeks. And This also, baby with high risk can also be categorized using their birth weight. So if the baby having small gestational age, it means like the baby is like 10% lower than the normal birth, and then below 10% of the normal birth weight according to gestation. And average for gestational age means that the baby having 10 to 90% of the weight according to gestations, and large for gestational age means that the baby have 90% the weight according to gestations. So this is what I mean. So in risk factor for a premature delivery, if the mother smokes, if the mother older than 35 years old and younger than 20 years old, and then the mother have drug abuse, the mother has female partner abuse, the mother has a multiple gestation, the mother has uterine abnormalities, the mother and the baby also inside have fetal anomalies, and the mother have infections like chlamydia, gonorrhea, or bacteria vaginosis, and the mother also have cervical anomalies and also history of previous preterm, then this will increase the risk factor for the baby to also be born prematurely. And even with the descendant of African American, they will tend to have premature babies, as well as there is genetic susceptibility, then the baby will be born premature. What I mean about the gestational age is that, so let's say we have a baby. She was born on 35 weeks and her weight is 3.6, so she will be up here, large for gestational age, so it's a bit heavy. But then we have another baby, a boy. He was born on 30 weeks, and then his weight is only 2,000. So he will be here, an average for gestational age. Obviously, he will be premature because he is not mature yet. And then we have another baby who was born on 33 weeks and only 1,000 gram. So the baby will be here. So this is what I mean for small for gestational age. So this baby, the last baby, will be a small baby for gestational age. So with the lower birth weight, so infant with lower birth weight tend to have the small for gestation age, which they have only 10% of the weight according to gestation. And this also can be categorized into extreme low birth weight, where the weight is less than 1,000, and then very low birth weight, where the weight is less than 1,500 gram, and then low birth weight, where the baby weight is less than 2,500, because we understand that normal baby will weigh around 2,500 to 4,000 gram. And we also know what we call intrauterine growth restriction. It means that the conditions of growth of the baby is being restricted because some problem, for example, is a placenta, a problem, it's a cord problem, so you have problem with your cord that the baby will not get sufficient nutrition that the baby needs to grow. So that's what called as intrauterine growth restriction. And mostly the baby will also be categorized as lower birth weight or small for gestational age. And for the small for gestational age infant, there are some conditions that also contribute, and these happen because the baby inside the pregnancy already have a deficit in their nutritional and oxygenations, which can cause from the mother, from the fetal itself, from the placenta's problem, or the umbilical cord problem. So what can produce a small gestation age newborn? It will be like genetic factor, if there are like chromosomal factors, if the mothers have fibroids, mothers has asthma, mother with hypertension, the mother used drugs, the mother has congenital heart diseases, the mother has diabetic, the mother has immune system sickness, and then the mother also have something problematic inside the uterine, and it's like having two baby at the same time, twins. So the TT transfusion problem, that one baby is having more than the other baby, so the other baby is small. And then if the uterine of the mother itself is having problem. And the last that reason happening to the women is like that the mother can also have torch infections from like having PATS or something similar. So these are 4 conditions that I'm going to explain that always affecting small gestation age infant. So the first one is hypothermia. We understand last time that baby lose weight, no, baby lose heat quicker than adult. And then with hypothermia, it's worse because the baby itself is small, and then the baby doesn't have so much brown fat and subcutaneous tissue. And as a baby, it needs a lot of calorie, and then need a lot of rest. And then the baby also have a high metabolic rate and low in glycogen because nothing there, no fat. So it's really contributing into the fact that baby will have hypothermia. And also that the baby temperature will be lower than 36.2. The body will be cold, it's pale, sometimes baby can shiver a little, and also we understand that the baby quick to lose heat. So how to diagnose it? We diagnose it with the baby temperature. If the baby temperature is lower than 36.2, it means that the baby have hypothermia. And as a nurse, what you can do, you can try to have a thermoneutral environment, which means we try to make the environment not contributing so much in baby heat loss, and we put the baby inside the radiant warmer or incubator, or even we can do like skin to skin care or kangaroo care with the baby, so the baby won't lose so much heat. Another problem or condition that can happen is regarding pain. So we understand that the baby, if it's small gestational age, it means the baby is premature also, and we need to do a lot of medical procedures which increase the pain. And we can see the signs and symptoms on the baby having pain as having a shallow breath, baby sweating, baby looks uncomfortable, sweating, crying, or sometimes even not crying at all. But then we can see that the grimace, the face expressions showing that the baby have a lot of painful experience. How to diagnose? We can just use the pain scales such as Premature Infant Pains Profile. I'll explain in the next slide. And what we can do as a nurse, we assess the pain as the 5th vital sign, assess every 3 hours, and if it's more than 6, it means that the baby have a potential to have pain. So as I mentioned before, this is the Premature Infant Pain Profile, and here we can see we have the gestational age, behavioral stage, heart rate, oxygen saturations, the brow, and then the eyes, and then the nasolabial furrow. So we will see that how is the baby? Is the baby quiet, active, or quiet or asleep? And then how is about their heart rate? Is it more than or less than? And how's the saturation oxygen? Is like getting increase or decrease? We can see from that, and we can see also how's the brow of the baby, how's the eyes looks like, and how the nasolabial furrow on the baby. If the baby then have like all 3, it means like even 6, the baby then will also have pain. So another condition is what we call hypoglycemia. So from the name, we know that glycemia means glucose. So the baby eventually needs more glucose. And what we can see that the baby become agitated, the baby become weak on feeding, baby become cyanosis, baby sometimes also show no shine or symptoms because it's just too tired, and sometimes baby also will cry loud or even no cry. So we just have to monitor whether the baby really having hypoglycemia through the blood sugar level, which is less than 60 milligrams per deciliter. So what we aim is that we need to monitor the blood blood sugar level. We need to target of 670 to 100 milligram per deciliter blood sugar. We can collaborate also with the doctors, the pediatricians to do an IV glucose if needed, as well as we can collaborate to give an enteral feeding like breastfeeding or another substitution for breast milk if needed, so we can make sure that the baby will have enough glucose. Another problem is what we call polycythemia. Like polycythemia, it means that too much blood cells inside the body of the baby. We understand that once the baby is born, the placentas come out, and then we have to cut the umbilical cord, and then all the blood that was from the placenta will move to the baby's body. And because of the immature blood circulation and regulations in baby's body, so there are just too many red blood cells, and these too many red blood cells will show signs and symptoms on the plethoric skin, and sometimes also delayed capillary level time. The baby will have hematuria and then proteinuria. Sometimes also can cause necrotizing enterocolitis, pulmonary hypertension, thrombocytopenia, jaundice, and other neurological problems. And how we can see that the baby really having polycythemia is actually by doing a blood study. So we value for the venous hematocrit of baby more than 65%. And as a nurse, what we can do, we need to do frequent urine analysis so that we know whether there is blood inside the urine. Then we do blood analysis for hemoglobin, hematocrit, and bilirubin to just make sure that everything will be under control. Another thing is that premature baby also born before 37 weeks, so we call it preterm. And premature baby can be categorized into severe prematurity, which the baby born between 23 to 26 weeks. And we also have moderate prematurity, where the baby born around 26 to 30 weeks. And we also have premature, where the baby born before 37 weeks, or preterm or late preterm. And the premature baby obviously smaller than a term baby, because a lot of things inside her and him is not maturing yet. So supposed to be matured inside the uterine, but something happened that he or she was just born before the time, and it's a premature baby. And when the baby is born during this time, the premature baby is very high risk for respiratory distress syndrome, apnea of prematurity, jaundice, retinopathy of prematurity, anemia of prematurity, and sudden infant death syndrome. So these are the things that really contribute into the death of the baby. So as a nurse, we really need to take precaution on what we can do to just prevent, or just giving the best nursing care that we can. So these are some pictures of premature babies. So we can see here premature babies with CPAP, and then this is also premature babies, and the mother is doing kangaroo care as well as the father. This is how nurses, they take care of premature baby, and sometimes the incubator look like this, because this is what we do to ensure that we creating environment that looks like the uterine, so thermo-neutral environment, as well as less stress for the baby, because coming out of the uterine before the time already a stressor. So we try to make a condition like feels like still inside the uterine, so the baby then can grow and catch up with a normal baby. So when we have a preterm infant, we need to do assessment, and we can assess this type of things through the baby. We can see that the skin is the skin still have tags and is translucent, having lanugo, very little subcutaneous fat, and very fragile and easily to injured. The head shape might be irregular, and we can see like a lot of fontanelles, a lot of fused sutures, bulging of the fontanelle somewhere, and then the penis of the ears are still flat. The eyes probably fused because it's still less than 24 weeks of gestation. And then we can see that the nose flattened, or probably the nasal patterns here not that pattern, and we can see that the ears also have a low placement. When we go through the chest, you can see that the chest looks like a funnel or a pigeon chest, and then we can hear a murmur And we can see that the nipples are flat, and then we can see the ribs on the cage, and then we can see and we can hear a grunting or nasal flaring or retractions on the ribs as a sign of respiratory distress. And we can also auscultate the chest on the anterior and posterior to just have a listen to the chest. Then on the heart, we can see the apical heart rate, and we can know that the heart rate might be around around 160 to 180 beat per minute. And then we can do heart auscultations also on the second and the fourth intercostal space, and then we can also listen to the heart sound, whether there is murmurs or not. And we can all do the blood pressures on each of extremities to really make sure that the blood circulatory system is working well. Another assessment on the skin that we can see is like sometimes a small tit for poor peripheral perfusion. Sometimes we can see veins, but it's like very prominent. Sometimes we can still see the vernix, and then we have a pale somewhere to relate with anemia from the blood loss that's happening. And then we have congenital strawberry hemangiomas, and sometimes we can see also diaperes. Another thing that we can see clearly on the skin is that the soles of the feet are really smooth without any creases. We can also notice if the head has visual anomalies, because this is preterm infant. And we can also continue with the chest. We can auscultate the respiratory rate for a few minutes, and sometimes it's around 60 to 80 per minute. Sometimes it can be above 80, but then we can understand that what happened, probably pain or other triggering moment. And we can see also that the chest might be moving asymmetrically through each breath, because probably there's like respiratory conditions such as pneumothorax or hernia diaphragmatic. And then we can also see that probably there are secretion, but most of the time there will be so limited secretions from the baby. And in the cardiac, we can also see whether there are cyanotic sign, and we can also see that sometimes maybe apex is still displaced, and then we can also see that the cardiomegaly might happen in the baby. Another place we can also assess are the abdomen, musculoskeletal, genitalia, and neurological or sensory. So on the abdomen, we can see that the cord is there. We have to see if there are 2 arteries and 1 vein. We have to palpate if there are any masses. We can also auscultate for the bowel sound. We can also measure the abdominal circumference, and we can also see if there are any enlarged for the liver and spleen. For musculoskeletal, we have to be sure that sometimes flexion are not possible for the baby yet, because it's preterm. And we can also assess if there are any fractures on the hips or dysplasia or fractures on the clavicle regarding as like very prone. And with the genitalia on male, we can see that the scrotum still is like smooth, there's no rugae, and then the testis not yet descendant. And on the female clitoris, we can see the female clitoris is really prominent, and the labia minora and majora is still there, it's not covered. So you can see it's like so obvious. And there is sometimes also the presence of inguinal hernias, and also sometimes the urethral opening for female and male are not very visible. Sometimes also we can find meconium coming out from vagina, and sometimes we can also not really recognize whether it's a female or a male, because it's just ambiguity on the genitalia. And sometimes also we have a problem with the bladder because it's just extrophy. And for the neurological and sensory, we can assess if the baby maybe have had lag in any of the positions, because basically not yet able to hold the head. And probably as a caregiver, we really need to be aware and be precautious about changes, like subtle changes that might happen. And sometimes also the sucking and the gagging reflexes are not present in the baby, so we just put in NG tube for feeding of the baby. Sometimes also we have the Moro reflex, sometimes we don't, and sometimes also we see that there are increase on the intracranial pressure and any signs that might be related to any cerebral problem that we really see. And then sometimes also will be hypotonia for the muscle tones and hypertonia for the muscle tones. And then sometimes we can see some twitches or even jittery or myoclonic jerks on the baby. Eventually the eyelids of the baby sometimes still edematous, and sometimes also it's not reactive to light. Sometimes it's even cannot follow object, cannot function as a normal eye on a term baby. And sometimes when the baby finally able to open the eyes, we can see that the baby have a nystagmus strabismus, which means the pupil will be in the middle. So it's kind of important for a preterm baby to have check on their senses, the eyes, the ears, and even the whole body, to just make sure that the body will be able to function as a normal baby. So these are some pictures of the prematurity that we can see. So the clinical evaluations for the posture, as mentioned before, that preterm baby sometimes can only extend, while a term baby can flex everything, flex the extremity, very nice. And then we can see the ears of a preterm baby looks like flat, and this is more like mature baby's ear. And we can also see the sole, so we can see creases on preterm baby sole, but we cannot see, it's like very smooth and nice on a preterm baby sole. And with the female genitalia, this is a preterm baby, so we can see that the labia majora present and very big, and close the labia minora with the clitoris on it. And then here you can see that you can even probably guessing this is not a female, because you see like the clitoris is very big, the labia majora is very small, and you cannot even see the labia minora. So this is what we can see on a preterm female baby. And this is what you can see on preterm male baby. So in normal term, you can even see the scrotum with rugae, and then you can see the testis descending already with a nice penis. And then on the preterm baby, we cannot see, probably there is a testis, or probably there is undescendant thread testis on the scrotum, and as in has rugae, and the penis sometimes is very small also. Another sign that we need to make sure we have is what we call scarf sign. So as you can see, a term baby can flex the can do flexion on extremities. So when we try to flex the arm, there will be resistance, but on a preterm baby we call it scarf sign, that the hands is not able to flex yet, so it's just like a long hand, like a scarf. You can just the scarf, the hands, and no resistance at all. Next thing is on the grasp reflex regarding the neurological evaluation. So on the term baby, as I mentioned before, we have what we call grasp reflex, and the baby, when it's a term baby, will have a strong grasp reflex. Meanwhile, the baby who are preterm, the babies will not be able to even grasp, and we need to support the hands to see whether there is a grasp reflex. There is grasp reflex, but it's like very weak because of the weak because of the preterm condition that the baby has. Another thing is the heel to ear maneuver. So once the baby is term, it's very difficult to bring the heel to the ear, but the baby, when it's baby preterm, we can see that the baby's heel can bring to the ear very easily, very flexible, because there's no resistance yet. So another few slides. It's about respiratory distress syndrome. So once the baby born, if the baby having preterm, it's a high chance for the baby to have respiratory distress syndrome. What is that? That's a lack of surfactant, the one that makes the lungs open and shoo all the fluid inside the lungs and change it to air. So when lack of surfactants happen, it means that atelectasis can happen. So imagine lungs as a balloon. So when there is no much surfactant, the balloon cannot go bigger and cannot contain air. So that's what happened. And because the baby is also immature, the balloon also itself cannot just be blown. It's really not functioning. That's the alveoli. So because the alveoli is not perfectly developed yet, so we have a problem to having a respiratory system, as well as maybe the alveoli is also collapsing because the lungs are just unable to function well. And the sign and symptom will be like the baby will look cyanotic. At the room temperature, the baby will have tachypnea, faster breathing with chest retraction and sometimes with expiratory grunt. And when we do the blood gas analysis, we'll find out that the result is hypercarbia and having metabolic acidosis. So what other diagnosis system that we can do? We can place the pulse oximetry and we will see that the baby is actually hypoxic with blood glucose level of hypoglycemia. When we do the serum calcium reading, it will show hypocalcemia as well. When we do the blood gas analysis, the PaO2 will show hypoxia with acidosis. So as a nurse, what we can do, we can help in providing oxygenation. So mechanical ventilation needs to be made to the baby using the endotracheal tube performed by the pediatrician, and we are going to attach it to the machine, ventilation machine, with the PEEP or positive end expiratory pressure when the baby weight is less than 100 grams. When the baby is bigger, we can change to another mode of the mechanical ventilations. After that, normally pediatricians will try to give you surfactant, synthetic surfactant, 15 to 30 minutes after birth, and then we can then slowly wean from PEEP to continuous positive airway pressure or CPAP, and then once the baby can tolerate for breathing, we can then move to nasal cannule or then oxyhood. So oxyhood is just like a helmet with the oxygen on it, and it's like more comfortable for the baby because you just put the oxyhood upon their head, and there's no like insertion of ETT that needed to be done to the baby. Another thing is once the baby can stabilize respiratory, then we need to perform monitoring for the blood gases. We need to see whether the baby will come again to hypoxic state, acidosis state or not. Then we can also take a look on electrolyte level of the baby, level calcium and blood glucose level to just make sure that the baby is going to thrive. And after respiratory distress syndrome, we can learn about asphyxia. So what is asphyxia? Asphyxia is actually a condition when there is insufficient of oxygen supply, or just basically that the lower level of oxygen inside the blood, which means that so many part of the body is suffering for lack of oxygen. And there are a lot of etiology that could happen, the same like the preterm baby. Asphyxia can happen intrauterine because hypoxic ischemia or probably anemia shock, which included if like their umbilical cord has a problem, then the baby obviously having a hypoxic ischemia condition. And when the placenta just like abrupt from the uterine, it means also that there's no supply from the mother, so baby can have asphyxia inside the womb. Another thing during intrapartum or delivery is that when the baby having birth and then the mother cannot contain normal birth and then having birth trauma just because of shoulder dystocia or like breech presentations, or maybe just because the umbilical cord compressions, which then includes hypoxia ischemia conditions that leads to asphyxia to the baby. Once the baby having been birthed, postpartum care also sometimes can cause asphyxia, probably if the baby have like a central nervous system problem, congenital neuromuscular disease or infection, or just simply disorder on the airway, disorder on the pulmonary system, and disorder on renal system. So these are things that can cause baby to have asphyxia. Another thing is that, as I mentioned before, asphyxia is its carry oxygen throughout your body. If it's prolonged condition of asphyxia, then a lot of effects can happen to the organ. So these are the effects that might happen to central nervous system, to cardiovascular, pulmonary, renal, adrenal, gastrointestinal, metabolic, integument, and hematology. So these are actually the conditions that will happen when asphyxia is really present on the high risk baby. Next is about jaundice and hyperbilirubinemia. So as I mentioned before, when the baby is premature, it means that the organ is not functioning well, and the organ that contribute a lot with the jaundice is the liver and the kidney. So if liver unable to do the conjugation of bilirubin very quick and cannot work together with the kidney, so then the bilirubin will eventually be inside the blood and will be everywhere. It doesn't occur on the day of birth, but sometimes 2 or 3 days after birth, and then suddenly the baby visible being yellow, and on the 4th day it reaches its peak, and on the 5th day these conditions start to disease, so that the baby will start to have a normal skin color, and this is what we call a physiological jaundice. Another chance for a premature baby to have jaundice is 90%, and for normal baby is like around 60%. And we also know what we call pathological jaundice. It means that the baby really have problem with their body. For example, if there's obstructive on the biliary tract, which cause biliary atresia, or a metabolic disorder, or hemolysis disorder, infection, or even just toxic disorder. And as a nurse, what we can do, sign and symptom, obviously we have to measure the normal unconjugated bilirubin is around 0.2 to 1.4 milligram deciliter, and we can see that there's like visible jaundice when the bilirubin is around 5 milligram per dl within 24 hours after birth. And to diagnose it, we need to really do a serum bilirubin on term baby, and if it's more than 12.9, then the baby surely have jaundice, and on preterm baby, it can be more than 15. So if serum bilirubin is like 16 or 17, it's definitely having a jaundice. And what we can do as a nurse, we need to handle it according to the cause of the jaundice. If it's physiological, we can do phototherapy. If it's pathological, then we can collaborate with another team of healthcare professionals to see what we can do. But then during phototherapy, we can do single, double, or triple phototherapy. We can also give hydration with electrolyte. Then we have to be precautious because bilirubin can cause bilirubin encephalopathy, which disturbance a lot on central nervous system, as well as what we call a kernicterus, so that the bilirubin can pass through the blood-brain barrier on your brain, and when the bilirubin reaches the brain, it can cause a permanent brain damage. So it's really important for us as a nurse to really have a precautions about bilirubinemia, and then also teach the parents that they also need to be precautious about the jaundice. So that's the end of my slides. If you have questions, please just put it on the forum, and please also do the readings to increase your understanding. Next slides are the references that I use for this class, so happy studying!